I'd like to welcome everybody to first in hopefully a series of tech talks put on by the professional interest group Diabetes Technology. I'm Dr. Joe Alloy. I'm the current chair of the interest group. I'm joined today by Ann Peters. She's professor of clinical medicine, the Keck School of Medicine, USC, and Jane Seeley. She's a doctor of nurse practitioner. She's got many other titles, including a master's of public health, CDCES, and she's at Weill Cornell. And I think Jane is never short of questions. So what we hope to do today is Ann, who helped participate in the tech section for the ADA standards of care over several years, really wants to talk about the evolution of device guidelines. And the way we're going to do that is with Ann presenting about a 10-minute just to frame the discussion. And I'm going to turn it over to Ann and Jane, just have a dialogue where Jane is going to be looking at a series of questions that have been prepared in advance, but we want to engage people in the audience. We'd like to be involved, and you can put your questions in the chat box, and we have an ADA group that's going to be monitoring the chat box and presenting the Q&A. I'm not seeing the next slide to go through, so all I've got is a small view here because I'm coming to you from an undisclosed location. So what I'll do next is, I know that we've got a slide.
The Diabetes Technology Interest Group, we're going to talk about that. Yeah.
The other problem is I just can't see the slide, but let me see if I can get to a different screen for a second. I think if I do, it then mutes me. So do you want to take over, Ann or Jane?
I'll take over because I'm going to talk. So I think the slide that's showing is the Diabetes Technology Interest Group. And I must say this has been a wonderful group to work with. And we've really tried to move ahead what we're doing because obviously technology is a field that's changing very rapidly. And we like to share ideas and then share them with you. So if you could go to the next slide. This is what we're going to do today. Obviously, we're making a few announcements. Then there's going to be my slides, a moderated discussion and question and answer. And we love the question and answer part the most because then it's as though we're actually talking to you. So we have a Q&A box where you can submit questions and then we will answer them. And basically, as I said, I'm going to go through just a few slides and then we'll get you to the discussion. This just shows you how to get to our member forum discussion posts. I know that we have this for all the interest groups. And I actually find it personally really interesting, not only for the technology interest group, but for others as well. This is an upcoming webinar, which is basically called 50 Diabetes Care Tips in 60 Minutes. It kind of slightly makes my head spin, but I think we may all learn a lot from this. So I encourage you to register. And I think we have really a good group of speakers from a variety of different perspectives. So this is me. And basically, I'm going to go through the evolution of the guidelines from my perspective, and I'll give you that in a minute. So the next slide is my potential disclosures of conflicts of interest. And then the next slide is really the beginning of this whole process. So surprisingly, we didn't have a separate section in the standards of care about devices until the 2019 standards of care. It was just kind of mixed in with everything else. And remember that the standards of care are written the year before. So in 2018, the Professional Practice Committee who writes the standards was working on the standards of care that were going to be the first ever device guidelines. And there's always one champion person within the Professional Practice Committee who takes a section. And the device section has been section 7. And then that person uses a couple of other people from the Professional Practice Committee and can ask for outside help. So when they started trying to do the 2019 standards of care, it was really, really hard to do this to start with, because it was really hard to just focus on devices and figure out how that fit into the other standards of care. So they asked for me to help do these guidelines. So I wasn't officially on the committee yet. I had been 15 years before, and then I was asked to be on the committee going forward. But here I was an advisor. And it's interesting to look back as to what mattered to us back then. And one of the really important things when you write guidelines is you don't want to make people feel like they're not getting good care. So if we say everybody should have X, something very expensive and high tech, and somebody's living in an underserved area where they don't have the resources to get that thing, we don't want them to feel cheated or left behind, or we don't want to say that we ignored their needs. So we start out by talking about syringes and pens. And we say basically that people who require insulin can use syringes and pens. And we say syringes because there are a lot of places where people don't even have access to pens. Now, as we move forward, we actually talk about pens as preferred, but here we just talk about both, very importantly, because we wanted to make sure that everybody was included. And then we subsequently discuss insulin pumps. And then a lot of this guideline was about using SMBG, because this was in the days when we had to fight to get our patients enough strips to test often enough. So we wanted to be sure that there was no limit to how many strips people could have, and we didn't put up to 10 or up to 6 or up to anything. And this again was when insurance companies were limiting us in terms of how many strips we could get for our patients who needed to test more often. Then next we talk about insulin pumps, which are the next slide, perfect. And we basically say that most people, and again, this has to do with a recognition of the fact that not everybody has access to the ability to do something that is intensive, because again, we don't want to be exclusive, we want to be inclusive of everybody. We say that most adults, children, and adolescents with type 1 diabetes should be treated with intensive insulin therapy with either multiple daily insulin injections or an insulin pump. And we give that a grade of evidence of A. And it's important at some point to review the levels of evidence, because this is important. Level A is the highest level evidence, which we consider well done randomized controlled trials. And then the levels go down. B is more really good large observational trials. C is basically some trial data, but that doesn't rise to higher levels. And then E actually really matters, because E is basically our opinion. And a lot of things in life aren't actually studied, because we don't study things, for instance, like, do we really need to have patients test their glucose before they drive? We actually recommend that without having a randomized controlled trial. And I think it'd be really stupid to have an RCT with people not testing their blood sugar before they die and crashing. It's a bad outcome. So there's a lot of stuff that's E that's just common sense, but common sense actually is important. So I don't think level E guideline are bad, they're just different. And then we talk about insulin pumps, that they may be considered in kids. And then we move on to continuous glucose monitoring. And we look at CGM, and this is where these oddball terms come in. And I can say anything I want because I was part of writing this, but we say is a useful tool, because we don't here want to mandate it, because a lot of people didn't have access and we didn't have a lot of data. But we say, we sort of hedge our bets, and we say real-time CGM in conjunction with intensive insulin therapy is a useful tool. And here is actually where we start to actually use different terminology, which evolves, but we separate real-time CGM, which is CGM, which has the ability to give both alarms and alerts and predictive alarms and alerts, but also are studied in RCTs, versus intermittently scanned CGM, which has a different body of evidence and, as we all know, is a different tool. So then we talk about it may be a useful tool of hypoglycemia unawareness. And we're trying to stick to what there is in terms of clinical trials data, that it should be used. That's finally a should statement, and then may be used in pregnant women. So those are what we start with for CGM. Then we move on to talk about it in children and adolescents where there's less data. And the data, as you'll see, doesn't really change. It changes, but we really want to make sure that people that need it, who are kids and adolescents, have access. And this is in part because when you look at the JDRF study, in which this was done a while before, looking at the use of CGM, they didn't see a benefit in kids and adolescents. And we didn't want people to say kids and adolescents can't use CGM because of that trial. And that was an RCT. We don't actually care. So here we're sort of saying, well, we still think it should be part of what we use for treating kids and adolescents, even though it was then and is hard to show consistent benefits because kids are kids, and most importantly, adolescents are adolescents, and it's hard to show a lot of improvement with some of these tools. So then we move on to looking at what we have then, which are sensor augmented pumps, and we say they may be considered, and we give that level A evidence because there was RCT data that showed it. And then we say that you need to give people education when you teach them how to use CGM, and that's level E because you can't really study that because you can't not teach somebody how to use something and test it. And then that was the basic thrust of what we talk about in 2019. So these are the 2022 ADA standards of care, which are what we now have. And I know it seems like baby steps, but trust me, every step along the way is an evolution based on published literature. And the data must be published by something like July of 2021. So that's when we review it. So this is data that's published, and it's not just an abstract published in a peer-reviewed journal that gets us to these standards. So now we basically start with this overarching headline that says that we really think that these guidelines and what we're talking about with technology has a set of overarching goals and recommendations. And we, for the first time, include caregivers in the decision-making process. But this really matters both for kids, but also as people get older. You've got to have a group in some cases. I see a lot of people who are underserved who have significant disabilities where the caregivers are using the devices. We discuss device use in schools. We talk about early initiation of devices. And over again, we talk about choosing the right device for the patient. And as we talk about throughout the ADA standards of care, it's all about individualizing care. So we finally take out this weird phrase, a useful tool, and we change it to should be, finally. And we now say that real-time CGM, which has level A evidence, which means that there's RCTs that support it, and intermittently scanned CGM, which primarily has data from these really well-done observational trials, should be offered for diabetes management in adults who are on MDI or CSII, who are capable of using devices safely. And we don't specify type 1 and type 2 here. We basically say anybody on intensive insulin therapy who's an adult should be on a CGM. And I think that's great. And I'm very proud of us for getting to this point. And again, we talk about the need for individualization. In terms of additions, we now talk about using CGM in people on basal insulin. So the data comes a lot from the mobile study, which puts our real-time CGM at level A evidence, NIS CGM is at level C evidence, but either can be used. And we say they can be used for diabetes management in adults on basal insulin who can use the devices. And again, we talk about use by themselves or with a caregiver. And then we talk about youth, and the data for real-time CGM is level B in youth. And there really isn't much thus far published ISCGM data, at least not in terms of the guideline cut point for last year. So that was level E because we think people should be able to use either device in terms of managing youth who have type 1 diabetes, who are MDI or continuous insulin infusion therapy, insulin pumps. But we don't talk about type 2s in youth because there is zero data on this, and we didn't feel like there was enough expert opinion. Personally, I think if I had a person with type 2 diabetes who was younger and I felt like they should use CGM, I personally would use CGM, but we just didn't have guideline availability. The data wasn't there for people who are young people with type 2. But, where you cut this, is it 18? Is it 21? I would say 18 is probably the cut point here in terms of looking at data. Now, the next slide basically is the final slide. And this is actually the most data-driven recommendation we have, which is that automated insulin delivery, AID, is strongly recommended as the most effective treatment option for managing type 1 diabetes. And this is because we really do have good RCT data looking at AID systems, and they really do better when they're compared to other ways of managing type 1 diabetes. We know this, but again, we also know that there are places in people where this is not their preferred method or a method of treatment that isn't available. So we obviously give all the other options for treating type 1 diabetes. So let's move on. And I see that there are comments. And that is my last slide. And I can see people, and I love that people are already responding.
Well, thank you so much, Anne, for this overview of the differences. And it's really amazing what's happened in 4 years' time and will still be happening. Do we have something in the chat that we should respond to now, or can I go on to my list of questions?
Well, wait, but I'm going to respond to Steve, who is actually quite correct. We only have true RCT data for one AID system, and the rest are basically comparisons to baseline. So he is correct in that comment. He knows this even better than I.
Anything else?
Can we have access to the PDF? Absolutely. You can have access to anything that I do. The actual slides, I think we can give you. So, or else you can just email me and I'll send them to you. And the other thing, I'm sorry, I'm just answering the chat. I'm just chatty apparently this morning. It says, can the AID system recommendation be for LADA as well? And since we don't actually recognize LADA as a thing, we either call you type 1 or type 2, since in my brain, all LADA is actually type 1, even though there's the complexity of how it's managed. If you have what you might call LADA, but they're managed with intensive insulin therapy, they can be obviously eligible for AID. Oh, and Steve agrees with me. Thank you. Maybe we should have had Steve on this.
Well, he is kind of on it. He's going to help along. So
okay.
let me ask you a question. With CGMs, we now have several different products on the market, and the implantable CGM has just grown to be able to be worn for 6 months, which is a great plus. What do you see as important features that matter in CGMs? What would you like to see in the future that we don't have now? And particularly for people with type 2, what would it take to get more people with type 2 to start wearing CGMs?
Well, those are all really good questions, or one giant good question. I think that everybody, and by the way, I only speak through my patients, because the way I learn about any of this is from what my patients experience. And when my patients wear CGM, there are some who don't want to wear it because they don't want to be bugged, or they don't like to wear something on their body, or they feel like it falls off. And there's all sorts of people who don't like that. And you know what? That's obviously their choice. But I can get a lot of people to wear CGM by working with them and my educators to try to make it so that it's comfortable, so that it doesn't fall off. There are all sorts of tricks to this. But I think that there are a number of problems just with it in general. It is something that sticks on the outside of your body. It's got tape that you can be allergic to. It is obvious to people when, people are wearing their arm and they're wearing short sleeve shirts, or somebody hugs them. I mean, it's something outside. And the ever since getting approved for a longer duration of time, for 180 days, may make that barrier something easier for certain patients to deal with. Some people don't like the alarms and alerts. And I think working with people to set the alarm so that it doesn't over alarm them is a good thing. I have, wear these devices just in order to see what it's like. And I can tell you that when one of these things alarms in the middle of the night, I really resent the heck out of it. And I know that people with type 1 diabetes, particularly who are alarmed a lot at night, they and their partners don't get sleep some nights. And I think that that can be really annoying. So there's a whole bunch of considerations when people are putting something externally on their body. So smaller, better tape implanted so that it's easy. But even that needs to last even longer and not require finger stick calibration. So there's a lot of pieces that we need to move towards. But I think that we are, so that the future systems, the Libre 3 and the Dexcom 7, are going to be smaller, easier. They don't have pieces. It may well move this forward. And then finally, it's all about cost. And if there's ever been something that was about to drive me out of medicine, it is the paperwork required to do what I have to do to get people these devices. It makes me insane. So I think that that's part of this. And I think that it's part of it for patients. If they rely on it and they suddenly have a time when they can't use it, it's really upsetting. And I understand it's really upsetting. So I think that getting access to devices is a very important part of this.
So we have a couple of really great questions I'd like to ask you. First one is, how do you get coverage for someone with just basal alone?
Well, that's tricky. Sometimes I'm pretty good at getting people things, but sometimes the insurance companies will just do it. So I've had people with commercial insurance where I order it and they do it. And a lot of my basal insulin patients sometimes have to give prandial insulin shots. I'm just saying. So not everybody on basal is just on basal. So there's all sorts of ways to manage diabetes. But I do find that people have gotten it with commercial insurance. It's harder to get, if not impossible to get, in somebody who's either on Medicare or Medicaid. And that's where my biggest issues have been. And some of those patients will purchase the CGM, particularly the intermittently scanned CGM, because that's the least expensive form of CGM. And they can get it at a cost that they can afford. But not everyone can do that. So that is a barrier.
I do think, though, we also have the possibility of them wearing it some of the time, that it doesn't have to be an all or nothing proposition. Many of my patients can afford to wear it, for the first half of the month, but not the second, or once every 3 months, whatever they can afford. Is some information is better than none.
Well, so yes. And also professional CGM, where I don't really like blinded CGM per se, unless I'm doing research, but I think that at least putting something on to get some sense of what's happening overnight in patients on basal insulin, because I'm often surprised. I see highs and lows and things that I never expected. But I would put CGM on everybody because I love the data, but it doesn't have to be continuous. I think that's a very good point in people who aren't on intensive insulin therapy.
We have a question about pregnancy, and they're wondering about people with type 2 diabetes and pregnancy. And I'm also wondering about people with gestational diabetes, because that's not covered at all because they don't have diabetes.
Well, all of this is thorny. So the FDA doesn't approve these devices in pregnancy, A. B, the data on pregnancy is hard to come by. We have the concept trial, which is a really good trial. But in the concept trial, which did show benefit in terms of outcomes with CGM, the people on the CGM were supposed to be testing their finger sticks 6 times a day. And yet, if you ask the investigators from the concept trial, were people checking? They weren't. They were just using the CGM. And most of my pregnant patients, nearly all, use CGM. And I do have them calibrate the CGM, or at least validate the CGM, because I want to make sure that we're not going wildly off. And I've used CGM in people who have type 2 diabetes who are pregnant. I've used it in gestational diabetes. We don't have data on either of those states. There will be data, I'm assuming, but I really love using it just to show me what's happening postprandially. I really believe for all of those states, type 1 pregnancy, people who have type 2 who are pregnant and GDM, it's useful, but it's getting it covered that can be problematic. But if I put pregnant in big letters on the prior auth, people often will do what I ask for because people are afraid of the liability of pregnancy. So they want to make sure I get what I want. But the default's always finger sticks, and people who are pregnant need to make sure that they have that availability and test if there's any thought that there's a discordance between the CGM and finger sticks. And then finally, for the patients with GDM, where I'll use a sensor, and again, sometimes people will just have to pay for it, I always have them do a fasting finger stick just to validate the system, because I want to be sure that I haven't, somehow gone off. I don't want to make a mistake, basically. I don't ever want to make a mistake, but particularly not in pregnancy.
You have a very interesting question. I'm not sure if you know this off the top of your head, but you know a lot. Or maybe Steve can chime in. What percentage of people with type 2 are on MDI or on pumps? Of all the people with type 2, it's got to be millions of people, though, when you think about how many people have type 2.
Well, I think a third of people with type 2 are on insulin. There may be more that should be on insulin, but a lot of the data is a moving target, because since we've had the advent of GLP-1 receptor agonists, we may have reduced the number of people who should be on insulin, but that's not as well used across populations as it ought to be. So I think that it's a much smaller percentage. And I agree with Steve, who says maybe 10% or up to 15% are on MDI or a pump. But I think it really does vary. I feel like we don't use it enough, particularly pumps in type 2s, but it's hard to get that covered as well, because Medicare at the moment doesn't cover it. But I really, if somebody's on MDI, it's a convenience. Again, it's up to the patient, but I have a lot of really successful people with type 2 diabetes on pumps.
So that brings me to the next area I'd like to talk about, which is pumps, and particularly pumps for type 2. So there are a couple of pumps that are designed for type 2. What do you think we need? What would be a perfect pump for someone with type 2 diabetes?
Well, my answer would be whatever makes it work for them, because it's always the person. But the perfect pump for anybody, to my way of thinking, is the simplest pump. And the pump that, an ideal pump, you wouldn't have to change the infusion set every 3 days. And the ideal pump, you wouldn't have issues with, infusion site problems and all sorts of other things and all the pieces and everything else. But for type 2s in particular, I think particularly because they skew older, that really simple is better. They may not need all the bells and whistles, but I like the notion of announcing simple meals, small, medium, and large. And I like the idea of it being something easy to fill. And I have, if you watch your seniors, and I know you do this, but try to even just fill up a pump reservoir and do all the steps that are required to put a tethered pump on. It's really hard. And so I certainly use pumps in my seniors with type 1 diabetes, but it's harder to get somebody with type 2, I think, who isn't used to the intensive management that you need to do some of these tasks. So I think it needs to be really, really simple and let them put meals in easily. And then obviously automation. So I'd love it to have, the automated insulin delivery at night in particular, because that can really smooth them out. But there needs to be bigger reservoirs, because people with type 2 diabetes often need more insulin. So it'd be a system that sort of met all of those needs.
Well, what about these smart pens? Do you think that might be kind of a gateway for people with type 2 toward pumps, so they would experience some of those features using a smart pen?
Well, I love smart pens. And actually, a lot of my patients who use smart pens don't necessarily move on to pumps because they like the smart pens. I like the smart pens because I can see the data. But again, it's based on the person. So I think, I hope we get to use smart pens a lot more in the future, and therefore are able to help patients do better. The best thing about smart pens in both my type 1s and type 2s is that it helps reduce stacking. And as long as someone can get the concept of insulin on board, which is easy to teach, it is sort of freeing to them. So I've really felt that it makes people safer in real time, and then it makes it easier for me to adjust insulin doses when I'm reviewing it in clinic. So I'm a huge fan. Again, whatever works for an individual is what's right.
It looks like in a short period of time, we'll have more smart pens to choose from too, which will make the market more interesting.
Yes.
What do you see coming that will be very valuable?
Well, I think that there's all sorts of fascinating technology that could be, out there that's going to be really valuable, and everything can be miniaturized and made all sorts of ways better. But the hardest thing for all of my patients is prandial insulin, is remembering to giving it in advance of eating. And I know if somebody told me that I had to do something, 10 minutes, 15 minutes before I ate, I think that, it'd be the hardest task of all of this. And any system that's going to make it easier for patients to deal with prandial insulin, and that does it in an automatic way, or at least just requires some sort of meal notification that the system needs to give more insulin. And then the other part to it is exercise, because I almost tie that in with eating, because you have to adjust the meal before and then adjust for exercise. And any system that we have that can make it simple for people to adjust for exercise or other variations will also be a better system. So there's a lot that we need to do to make it easier. But nowadays, since I have so many patients on hybrid closed loop systems, I'm almost spoiled because I'm so used to looking at normal nights. It's genius. And then I am so used to looking at days where I almost am like a broken record. This system would be better for you if you put your insulin in advance. I mean, that's what I say every day. And it's hard to do that for patients. So that's the kind of thing that I really feel like we need to improve.
It's interesting you say that, because I've heard a lot of controversy over whether someone should have an AID insulin pump if they're not doing what they're supposed to be doing to begin with. So, for example, they have a very high A1C and they're not following all the instructions. So some people will say, well, they shouldn't have a pump that does all these things for them because they won't utilize it. They won't trust it. How do you feel about that?
Well, I think it's interesting. So everybody's different, and it depends on the whys. And a lot of times people have really high A1Cs because their life circumstances are really tough. So I have a lot of under-resourced patients whose jobs don't let them test their blood sugars at work, whose jobs don't let them eat snacks at work, where they really have to keep their sugars high because they're so afraid of lows, or people who are depressed or have an eating disorder, who have all sorts of psychosocial conditions that make it really hard to deal with this very difficult disease that requires numeracy and literacy skills. So I feel that there's not just one reason for people having higher blood sugars. So therefore, there's not one reason why I would put somebody on one system or not. But I try to deal with the reasons that someone got to those high sugars. And then if somebody's sugars are high and they're really working with me and we're dealing with some of their barriers, I love putting them on technology, but I tend to step it forward. So if I have somebody with a very high A1C and I put them on a hybrid closed loop system, they go down too low too fast and they feel miserable, and all those fears of hypoglycemia come roaring back. So I tend to start people on CGM before I put them on the whole system. And the CGM just lets me help them see, and then maybe a smart pen. But I do what I can to lower them slowly. And I actually have taken patients with high A1Cs and put them on loop, which is the do-it-yourself system, where I've set the targets quite high and then gradually brought them down. So it, like with everything in diabetes, there's not one reason people's A1Cs are high. So you have to tease out why and then choose the therapy that makes the most sense. Now we have like 1,000 questions. Are you,
They're not coming over to the Q&A. I don't know why that is.
No, they're all on the chat. So there's tons of questions.
They were supposed to be sent to the Q&A.
Yeah, we can't access the Q&A at this time.
Oh, I wish you told me that. I've been wondering.
So, yeah, are you seeing the question about is the ADA position with respect to CMG, CSI for type 1 diabetes same if it's closed loop or not? Are you seeing that question?
Yeah. So the question is, what is the ADA position with respect to must be CGM and pumps for type 1? Is it the same as closed loop?
No, because the actual data on CGM, so this is the way it works. Again, we don't want to exclude anybody or any preference. So the data on pumps versus MDI is not compelling the way the data versus the AID systems look. But if an individual wants to be on a pump and CGM without the automation, that's fine, but it's not considered the same level of evidence. But again, we don't eliminate any treatment approach, particularly if it's working for a patient. But we believe that the automated systems are now and increasingly into the future going to be the best way in terms of achieving glycemic outcomes. But there's also a lot to be looked at in terms of patient-reported outcomes and other kinds of ways to look at what is a good outcome. So if somebody's doing well in what they're on, change isn't necessary. Now, there's so many good questions in the chat, I almost can't read them all.
Here's one about, do you foresee FDA officially approving CGM for hospital use after the public health emergency?
I don't pretend the FDA necessarily. I would hope that they would, but I believe that they ask that we give them more data to show the safety and efficacy. But I certainly think that the pandemic was able to show us that we could use CGM in hospitalized settings and that it could be beneficial. So I am very hopeful that they will look at it that way. But there are steps between here and there that are necessary.
We do have a lot of data now that we didn't have before, though, since the pandemic, because so many people are doing it. So I'm hoping we might have enough to be convincing.
Me too.
The patients love it in the hospital. It's very interesting. Okay, there's so many questions here. I'm sorry, I was waiting for the questions in the Q&A and they were all coming in the chat and not moving over. Okay, how do you see the evidence of developing for CGM for behavioral modification in type 2?
So these are such good questions. So in the studies in type 2 diabetes, like in the mobile study, people don't get better because we changed therapy. People got better because they used the feedback from the CGM in terms of their behaviors, or at least that's what we surmise, because insulin doses didn't change, other therapies didn't change, but people got better. And there are a number of other studies where CGM in type 2s really drives people to change their behavior. The problem with doing this in terms of studies is that you put something on people and you try to change their behavior, and half of them will change their behavior and the other half won't, and then it looks like it doesn't make a difference. So the problem here is to prove it. But I believe that I certainly see patients who change their behavior based on CGM data. And I think that that's invaluable for an individual. So the evidence to prove it is hard. And you often change too many things at the same time when you put CGM on somebody. So I know people are looking into this, but I also wouldn't hold my breath that we're going to have a great set of data, because again, it's hard to quantitate what people are doing behaviorally. And I just think it does work. If you're having someone on the CGM, looks like in the old days, people used to check their finger sticks and do nothing and change nothing. it seems to me unnecessary to do anything, especially if it requires poking your finger or wearing a device where it doesn't do anything. But in my patients who really feel that it's a benefit and it helps them modify their behavior, then why not? As a corollary, my partner has type 2 diabetes and he loves candy. And if I put a CGM on him, I almost have a heart attack. Now he's got a decent A1C, but his post-candy blood sugars go up. And he doesn't want to wear a CGM because he knows what happens when he doesn't follow the rules. And he doesn't want me to bug him. So I am pointing out that there's good and bad to the behavior modification, but people don't have to look and they don't have to wear it. So this is complicated, but I think that we need to tie CGM with our educators, with our dietitians, with our team to use it to help everybody do better. And so I think it's got to be coupled with all of that, but I think it's going to be hard to prove.
So here's a question that is so perfect for you. About your work in underserved communities, what has been your experience with the uninsured and underinsured to get them to have increased access? What have you been able to accomplish?
Well, I don't want to gloat, but I've actually been able to accomplish nearly everything I need. So the way I did it was working with the Department of Health Services of LA County, and I've been working with them for 20 years. And we first managed to get analog insulin on the formulary for type 1s. And then I worked really hard with the state of California, the Medi-Cal, which is what we call Medicaid board, to get them to approve CGM. I even went to Sacramento and talked to the state assembly and the healthcare committee and pushed and pushed and pushed to get bills signed. And then I got our local Medi-Cal HMOs to cover it. And then I got a human being magically provided to me whose job it is in our clinic to do the prior auths because they're so onerous. And then during the pandemic, the Helmsley Charitable Trust and Insulin for Life gave me boxes of CGMs, which have intermittently scanned CGMs, which I could just give to patients. And we actually mailed them to patients. And then I started a donor program so that you come to my clinic now and every single person who's on multiple daily insulin injections or a pump gets a CGM, and they get a CGM either through whatever we can do from their insurance, or we mail them boxes of CGM for free. So I give everybody CGM. That's a baseline. And then we've worked it out so that the health insurance plans for certain kinds of Medi-Cal, and it's tricky, can get insulin pumps and hyperclosed loop systems. So in patients who have the numeracy and literacy skills to use those technologies, and we've also created low literacy teaching guides because the guides for use of technology are written at about an 11th grade level and not in Spanish that our patients can understand. We've created teaching tools and we're able to employ all sorts of technology there. Now, there's all sorts of reasons that people have trouble using technology, and I can make people's PROs improve. I can help their quality of life with technology. I can't always improve A1Cs, but at least I now have it so that everybody can get access to pretty much all the tools they need, but they still need more. And that's what I'm working on.
The next question has to do with downloading and interpreting the data. And I know that that's a big challenge for many practices. And I know you've been involved with some coworkers and have a good system that you've gotten in place. So can you talk about that?
Well, yes, but I also want to say that there's a question about linking to the low literacy teaching guides. And I am bucking the ADA because you guys at the ADA said, and you're working on a link to the low literacy teaching guides. We have 42 guides. There's another grant from the Helmsley Charitable Trust, and we have them in English, Spanish, we have them for adults, we have them for peds, we have them for teenagers, we have them in millimolar, we have all of these guides available. So hopefully the ADA will be able to provide a link soon from their website to our guides because we want them to be available to everybody. Now,
Is it only in English or is it other languages as
It's
well?
English and Spanish, and we use the Clear Language Group, and it's in Spanish that's been vetted by our community advisory boards who are native Spanish speakers. So it's simple Spanish and simple English. You can't make it too simple because the technical terms, which you can't take away, increase the literacy level, but we've made it, I think, at a 5th grade level, which is the lowest we can do. But it's, and then, you know, it could be translated into any other language. Every bit of it is not is not copyrighted. So we want everyone just to use it. And Mark, you gave the USC link, our current link, but I want everybody to know that the ADA is working on this so that it will be linked to the ADA. But yes, use them all you can. Now, wait, the getting data. So the getting data is also really hard. But the part about getting data for a lot of my under-resourced patients is that it requires a smartphone. And a lot of my patients don't have smartphones, and it makes it hard. But patients who do have smartphones, I have my educators link them to the clinic's cloud-based program for whatever the device is, and then we can just look at the data. So I have systems both in my East LA clinic and in my Beverly Hills clinic to get the data in advance of the visits with me so that then I can review it and see the patients. So I think getting data requires working with the patients. And if they have to plug it into a computer to figure out how they do that, if they can stream it to you, it's even better. And then having somebody get the data for you in advance of visits, particularly telemedicine visits.
That's really great. What about, we talked about some unmet needs, but what about other things that we want to see? Like, for example, with pumps and sensors with different languages. What's missing out there that we would like to see happen?
Well, has anyone noticed that Dexcom and Tandem and Omnipod don't have guides available in Spanish? That's a real barrier for my patients. Libre does. They have it in many languages. So one of the real problems, at least for me, and in the United States where lots of people speak lots of languages, is we don't have guides that are in other languages. So I really want the companies who make the devices to make everything in certainly English and Spanish, but in all sorts of different languages for different populations, because it's a barrier. It's a barrier for my patients in East LA to use the Tandem hybrid closed loop system, because even though you can get information in Spanish on the device itself, you don't get it in Spanish and they can't understand it, or the same thing with Dexcom. So I want to push companies to do things to make these devices customizable in terms of language.
So I'm going to move to a whole different topic we haven't talked about, virtual health and apps. How do you decide when you're talking to a person with diabetes about recommending apps, for example?
Well, I don't know, perhaps you should answer that. The thing about apps is that so many of them are unregulated and made in somebody's basement by a 12-year-old. So I want to make sure that people actually are using apps that are legitimate and helpful. And so I know in the UK, they actually have a committee that chooses the apps that seem to be the most safe and effective, but they're not going to be studied. And there are FDA approved apps so that you can look at those. So anything that involves dosing or instructions on how to dose insulin have to be FDA approved. But there's all these non-approved apps that you really have to look at. But there's some that I'm just fond of. Like I like visual carb counting apps where people can actually see portion sizes and things. That makes it simple. But I really rely on my patients and my educators to tell me what apps are good. And then the problem with apps in general is they only work if you use them, and people will use an app when it's new because they love novelty, and then they give up on it. So I think it's important that there is no magic to apps. It has to be something people will use and continue to use. But in my mind, that the app is safe is the most important part. I don't want it to give bad advice. And we all know that there's all sorts of bad advice that you can get out there.
I also really think it's important before we recommend an app that we actually download it on our own phone and try to navigate it and see how hard is it to set it up and what kinds of things is it asking for. And especially, as you said, with the FDA approval for anything that's dosing insulin, it really needs to be FDA approved or it's not safe. And there has been, many that have been passed around that we had no idea how it was coming up with the dose. So we have to be very careful. There is a really good ADA publication on apps in diabetes spectrum about 2 years ago. I can't remember exactly the name, but something to do with, is there an app for that, which is helpful. And the Association for Diabetes Care and Education Specialists at their Danatech site, which is for members, does have an app rating system they've put in place. So there are some sources where you can get this information. Oh, somebody's answering me here. It's free to create an account. ADA membership is not required to get to Danatech. I didn't know that. Thank you. So that's great. What about for people that aren't very experienced with technology, with pumps and sensors and so on? How does someone become competent? What would you recommend that they do to learn more?
Well, I have them go to the company websites because there's a lot of information, but there's also information out there from people who use devices. And some of my patients like to connect with other people and get their experience. One of the problems in life is that people who do the best and the worst tend to post the most online. And so that you can sometimes learn things that may not be that helpful, which is why I do try to have people look at the actual websites for the devices and then talk to my educator. And there's also, you can get a fake little Omnipod and wear it and see if it works. They'll send you one. Or there's, ways to get devices and CGM and everything else that you can get as a starter to just try. So I would urge that people get those devices, get them from their educator, or at least look for them online and try to see if they like wearing the thing on their body, and then they can gradually learn about it. But I think that there really needs to be good teaching, and I think you can't get away from that. I think people can teach themselves, but I've already learned from talking on this, webinar. I learned from everybody, and I think that people learn from everybody when it comes to these tools. So I really work with people in slow steps. And I also tell people that you're not going to need to know everything all at once. These are the basics you need to know. And then people get better slowly.
So if you had a crystal ball, where do you think we'll be with pump therapy in 5 years?
Well, I'm more interested in combined systems. So if you mean pump therapy, I mean pump and sensor combination hybrid closed loop systems. But I want them to make a really cool insulin, right? That's so concentrated and so genius that it only requires a teeny, teeny, tiny pump. So you can miniaturize. I want everything smaller and smarter and have less issues technically. And I want it to be pumps, but the whole system, as I said, to be better at aberrations, at food, at exercise. I want it to be more automated in the sense that it doesn't require the person using it thinking so much about it. When I give a device to somebody, I say, this will help you take away the diabetes burden by 15% or 20%. I give them an expectation that you're going to have nights that really will be smooth, but then you still got to think about the days. But it doesn't take away the burden of having diabetes. And I think it's important to frame that these are tools. They're ways to make it better. And the more we can make the tools better, smaller, more reliable, more efficient, the better it is. But I just think we've got to work on doing that, miniaturizing it. But it's we don't change quickly. And I think that's one of the things about showing you all the guidelines is if you think about it, we've changed hugely from fretting over how many finger sticks we can prescribe for a patient to figuring out the stupid paperwork to get the prior auth through the stupid distributors. And I'm not dissing all distributors. I'm just pointing out that it's the bane of my life to get all this stuff through. But we're now having a whole different set of worries than we had in 2019. But I think that as we go forward, we're going to see that there's, more out there, but the change is always too slow, and yet it is actually happening.
So in thinking about the future and automated insulin delivery and improvements, what do you think is going to happen to looping?
Looping, I have absolutely no idea, because there are still so many patients for whom looping seems to be better. Looping's off-label. Looping requires a certain level of skill, but I have patients who do better than any existing system by doing it themselves. If we can make an existing system or that's FDA approved, that's as good or better than looping, then I think people won't need to loop. But looping is just, it's another way to get to the outcome that we're all trying to help people get to, which is the best control and the easiest way.
Right. So we're almost out of time. If you had one last thing you wanted to tell our audience, what would it be?
I think that we have more to offer than we ever had. And as I said earlier, we also don't want to oversell it. But I think we can help people be safer. And I think we can help people reduce the burden some. And I think we all need to offer these tools, and we need to offer it with education, with hand-holding, with as much connection as we can give people, because I think it's really hard to use these tools in a vacuum. So connect with your patients, and we also need to continue to connect with the patients who don't have access to what they need, and keep doing work with advocacy. The ADA does lots of good advocacy. Keep fighting. And I really feel proud of what I've been able to do in LA County. And I credit everybody within the county who's worked with me. Theodore Friedman has been a real champion. We've worked really hard to make this happen. And I think we need to keep working together. And it's bigger than any individual, but we can do it.
And, I want to add to what you're saying. It's really important to realize that every patient is different, and that many times people have surprised me that have been able to do something I would have never guessed they could do, given enough time and effort with them if they're willing. So, technology has a very broad amount of people that could do different things or not. And we have to figure that out with each individual. So thank you so much for getting some insight on all of your ideas about technology today, Anne. And thank you, American Diabetes Association, for sponsoring this Tech Talk. And we hope to offer many more from our little leadership group. And take care, everyone. And thank you for all your questions in the chat. I hope I got to most of them.